Lindsay and Dr. Bott. And it's just a very, very relevant topic, not just to therapists, but it's also extremely relevant when we're trying to promote change in our patients. And very often we get caught in trying to tell our patients what they should be doing, right? And so hopefully after the presentation, you're able to understand a little bit more about the transtheoretical model. What does each stage tell us about what we can do with our patients? And also, how can we use that in conjunction with the with motivational interviewing, right? So first of all, the transtheoretical model tell us or help us understand how can we work collaborative with our patients in what they need for treatment, right? And so sometimes our patients are ready for change, sometimes they're not. And so the transtheoretical model gives us a different perspective as to maybe what our message should be and even our approach. So for those of you who are not familiar, the transtheoretical model has stages, starting with the pre-contemplation, when I have no awareness that my unhealthy behavior is an unhealthy behavior, to contemplation, where I'm aware, not ready to change, preparation, I'm starting to prepare, but haven't done a thing yet, except preparing. Action, where I'm actually already making that change. Maintenance, I've been doing that change for quite a while. And relapse, and even though relapse is located in this area for the transtheoretical model, relapse can happen at any point in the transtheoretical model. And one thing that's interesting about the way the Prochaska and DiClemente developed it is they wanted us to see it as a spiral, meaning that you could be in maintenance for many years and all of a sudden actually go all the way back to contemplation or maybe even preparation, but it's not linear. And very often we think of change as linear. And this is a really helpful approach, because that explains why sometimes we might have somebody who goes into a relapse, even though they've been in maintenance for a while, and how they might go all the way back to even not feeling or feeling very ambivalent about changing. And one of the interesting parts in terms of the transtheoretical model is that there are places where we can apply motivational interviewing. If you see it here in the way that the slides, by the way, you will get a copy of the slides and they have more detailed information. You'll notice that in contemplation is where the patient has that ambivalence, has maybe an understanding that they want to change, that something is not beneficial anymore about their behavior, that they just don't know how to. And let me go ahead and go to the next slide. Okay, so one way to use the transtheoretical model is to understand what can we do with patients. Very often we assume that everybody comes in and because they came in, they're ready for change. And very often somebody else might be motivating them to change, or maybe their physician send them to a therapist to start doing therapy, or maybe their wife gave them an ultimatum so that if they didn't see their physician and made some change, they were going to leave them. So again, that understanding that depending on the specific stage, there is something that we can do. So in the pre-contemplation, when patients come in and they don't recognize that they may need to lose weight, they need to reduce smoking or stop smoking, our goal really is to listen, elicit, and communicate, right? So we really want to focus on that genuine collaborative relationship with the patient, where they truly feel like we have empathy as to what it is that they're sharing. And whenever we have the opportunity to be able to share some education that they're willing to listen, that's when we can start planting that seed, right? So so that the patient starts to wonder, well, maybe smoking for so many years and so many packs per week might not be a good thing. And so it starts to bring that awareness to the surface, right? Because what we want to do in pre-contemplation is start to instill that ambivalence, that wondering of maybe it's not a just steady state. Contemplation, again, is where we have that ambivalence, and we really want to focus on the change, right? Sometimes, believe it or not, sometimes in the way that we talk to our patients, we're actually keeping them in change. If you were to take a full course of motivational interviewing, one of the things that you'll notice is that even at times we're trying to use both types of language and concepts in terms of change and sustained change. You'll notice that we're at the same time that we're telling a patient why they should change, we're indirectly or inadvertently pushing them to not change. And so in contemplation, that's why we can bring in the approach of motivational interviewing, because it helps us develop and increase this discrepancy in what they feel, and start to address their self-efficacy, right? So we want patients to be able to understand also, to see that they have that autonomy to do certain things, not just us telling them what to do. And it's pretty interesting. I don't know if you've ever noticed, there are times where when we think of our patients, and even anybody that you are trying to talk to about change or any idea that is different than what they believe, one of the first things that you'll notice is the more you try to tell them why it is that you are right, or why is it that your way is better, the more they're going to tell you why it is that their way is better. And that's why both the trans-theoretical model and motivational interviewing can be very helpful, not just in therapy, but it can also be very, very efficacious when it comes to talking to patients in terms of treatment. The action state, it's a little bit different, right? So once somebody's able or willing to change, we don't have to focus so much on trying to convince them, because they're already doing something about it. So our conversation with our patients is more about, like, what are the barriers? What are some things that are getting on the way? How can we change that so that they can continue in that action state and hopefully moving into the maintenance state where they have been in change for a while. One thing that is very important to understand as providers, as healthcare providers, is that the word relapse that appears very often throughout the entire trans-theoretical model. In other words, that appears in our care, right? In our work with patients. That if we frame it in a way that it is hopeful, patients are actually going to feel more motivated. In the past, relapse has had a very negative connotation, right? Lapses and relapses. It's this idea that here it is, another failure, another reason why they just cannot be successful, another reason why they're very dependent on us, right? That there's no autonomy. And so we hold that power of being able to talk to them and share how relapses actually kind of hold a bit of a secret for us that we can unpackage as to what was the thing that was missing in terms of treatment, and that we can work collaborative. So if we are able to change the approach as to, and I'm showing you lines, I apologize, I don't know if, hopefully you, I'm not reading through all of them, but just in explaining, right? That if we can share that relapses holds the key for us to be able to go back and see what skills did we miss, what other elements did we miss that we've already been working on, then we actually help to encourage our patients to feel hopeful about their recovery. And very often we even make the differentiation between lapses and relapses, right? For the same reason, because relapse just has such a negative connotation. I think depending on other models, relapse can be a sign of again, having to start from zero, versus if we have an approach of the trans-theoretical model, if you remember that spiral, we're thinking, well, okay, so you were in maintenance before, so let's see what skills are you missing? How can we get you back into maintenance rather than having that patient just feel so discouraged, they go all the way back to pre-contemplation, where they feel like they have no reason to change. Right, so very, very key, very a very very unique spot to be able to talk about it. So why do we talk about motivational interviewing in the transtheoretical model? Because when we have a patient in front of us who is wondering, even if it was the patient that the wife gave the ultimatum for them to change, we're still having somebody who's intrigued. How can they do certain things? So at least to start with, it could be to stop the nagging of somebody, right? We can even use that as a way to help somebody set up their goals. And that's how motivational interviewing works. It's a very collaborative approach. And one of the key components of motivational interviewing is this idea that patients, they themselves know better how they can be best persuaded into making changes than us persuading them, right? So it's definitely something different in which we are talking with people, we're working with that collaborative for them to be able to make a change while they're in that ambivalent state. In terms of research, there is quite a bit of research in terms of motivational interviewing, and I'll share just a very brief overview. There are many trainings out there. We have a didactic on Wednesdays that presents it, but there are even more deeper trainings that you can get out there. But just to give you a little bit of a taste of the effects of motivational interviewing, here are just 2 studies. In one, for example, where the effect sizes were pretty large right after the treatment, where patients set up their own goals and set up what they were going to do, including talk about barriers and how they were going to address those barriers, and then continue with their change. And even after a year follow-up, the effect size was still a big effect. I mean, it's a medium effect, 0.30, but still was there. So meaning that patients continue with whatever area they wanted to change, even a year after, especially when it was at the beginning. Motivational interviewing was included at the beginning. I think often, by the way, often people think motivational interviewing can be applied at different stages or at different times. Again, think back to the transtheoretical model. It is important to know where the patient is at, to know if motivational interviewing is the best approach. If somebody's already ready to change, it would be pointless to use it. Another study, again, showed that effect sizes were pretty large, especially for changing behaviors such as reducing weight loss, reducing blood pressure, substance use. And here's a pretty interesting finding, which we do see across even as little as one session. After one session, patients feel like they're ready to change. Okay, so what is this ambivalence, that I'm talking about? So feeling 2 ways about something, right? Feeling like you want to change, but then just feeling almost like you just don't know how to, or start thinking about all the barriers and all the reasons why maybe you shouldn't. And all those thoughts of why not to change, that would be the sustained talk, right? What is it? What are my reasons to stay within? It's a normal part of the process, right? We must feel ambivalent to be able to want to change, but we should be really careful, because we can get in this communication trap. And in motivational interviewing, I think some of you have heard it before. It's called the writing reflex, in which we are really ready to tell someone what do we think they should change, how they should change it, how often, etc. And so what's really interesting is in training people on to do motivational interviewing, as they're trying to reduce this writing reflex, it's really interesting to see how it's just such a natural instinct that we have, right? We just want to, we feel like we have more information. We just want to tell someone, we just kind of want to shortcut and just prescribe it. So the writing reflex again, is me as a provider wanting to tell you how to do it because I feel like I'm the expert. But one of the interesting findings in terms of motivational interviewing, if there's an example that I have here in terms of a picture, and I'll show you the picture, the more you push with telling someone what they should do, the more the ambivalence is going to push back and saying, no, thanks. So you're going to hear a lot from your patients. The more you say, you need to stop smoking. And then the more they're going to say, well, yes, but it helps me with stress. Well, there are other things to do about stress. And then they're going to say, yes, but I don't have time for that, right? So the more you see that, the more you're going to see that pushback in terms of not wanting to change. Here's an explanation as to why that happens. Why is it that us providers more naturally, I should say, we feel like we want to tell our patients just what to do because we feel like it would be so much faster, is sometimes we don't even see it, that we're pushing what it is, that we're pushing, or we're, I saw a couple of faces, right? So we don't see it, we don't know. We start to assume that the patient doesn't know, we start to assume that the patient doesn't know how to, right? If they haven't changed, they must have not known, or whatever they used, it must have been inefficient. So let me tell them what's better, right? And sometimes we really plain out think our patients are just not motivated. They just don't care. And so in telling them, I'm going to make them care. I'm going to make them want to change. If I just tell them how bad it is to use meth, if I just tell them, if I just show them how scary it is to continue with the unhealthy behavior, that's going to convince them, which is not true. So what happens is that we feel like we're imparting insight, knowledge, and skills without really knowing if that's what the patient in particularly needs, right? So there's that push, right? I just wanted to show you the picture before, right? So the patient not only feels not satisfied with us, they might not even tell us. They might be sitting in our office, just say, yep, no, I got it, that's true, I will do that. And they come back in the next session, and what do we discover? They haven't made any changes, right? So nobody benefits from it. Okay, so here's a good way to remember not to do the writing reflect. Rule is a nice mnemonic. Resisting it by understanding our patient's motivations, listen to what it is that what are their concerns, their ideas, and empowering them because they can make the change, right? And here are just a few components. Again, this is not meant to be a training for MI. The motivational interviewing approach has the spirit, principles, and processes, and then the skills and techniques that you actually use. The spirit is, again, the collaboration, acceptance that my patient knows best in terms of how they're going to go about it. It is okay to share education, but if I'm going to share that education, it's with their permission, right? I'm not going to push it at them, right? And so you're having this absolute empathy and absolute worth of what the patient has to do. And then again, transferring this idea that they can eventually, with our collaborative work, do what they need to do to get better, right? To reduce that unhealthy behavior. I'm just looking both at time and at slides. Some of these extra slides just go into the details of each one, but again, remember, in terms of acceptance, if I tell them what to do, that's an authority approach rather than autonomy, right? And if the more I tell someone what to do, the less they feel like they want to do it. I like this idea of dancing. So in MI, we talk about this movement, right? So in wrestling, we're pushing against, and they're pushing against us. In terms of MI, it's more of a dance. The patient moves this way, we move with them. The patient moves another way, and we move that way. Another important component that is very present in MI it's in that collaboration is also the affirmation, right? Telling our patients how we are really happy that they're wanting to know, that we're really excited that they're exploring change, but doing it in a way that doesn't sound that is genuine, right? If you train in MI, you're able to even learn like how often should you give affirmations, so that it doesn't sound disingenuous, right? But that they're also part of that empathy, right? That they know that we also recognize what they're about to do. It's hard, but that they're willing and that they're brave in doing that. I think, let's see, so I'm just looking again at time. Evocation would be the biggest part, right? We are trying to get from the patient what it is that they want to do. So when we're sitting there, we are asking, right? So so it sounds like we can reflect back. It sounds like you want to change because you are feeling pretty tired about people just getting on your case for still using. And then the patient will confirm to us. And there might be occasions where we reflect and the patient says, no, that's not what I feel. It's like, oh, okay, well, can you share a little bit more about that? We're again, really giving that space for patients to share with us. So not only do they feel heard, but they also start coming up with where do they want to start, right? So if they're going to start a change so that they stop, their wife continues to nag them, maybe they say, I just want to reduce use for now. And so in MI, in a motivational interviewing approach, you would be talking about, okay, what would be the next step you would like to take? How doable is that? How confident do you feel? So that you don't get into this. And instead, when you're sitting in those sessions with your patients, you're actually moving along with them. I know this is a very, very fast overview, but it's a very essential topic to care, especially in the treatment of substance use. It's a very difficult thing to change because substances very often serve other purposes. And so taking away that purpose, maybe if it is avoidance, maybe if it is reducing pain, not in a healthy way, how is it that we are trying to tell someone to let go of the things that help them can be very difficult. So nothing like working with the patients in order to be able to see what change can that be and how can they do it can be just a very, very essential. So that is the end.